So good afternoon, everyone. So very good afternoon. I hope you are revising your notes. So yesterday we discussed about sympatholytic drugs, and the first drug we discussed was central sympatholytic, okay, like clonidine-like drug. Then we discussed about the effect of catecholamines on our blood pressure and heart rate. We discussed about vasomotor reversal of Dale. Alpha blockers, they are vasodilator, they show vasomotor reversal of Dale. Beta blocker, re-reversal of Dale. So today let's discuss about the last topic of autonomic nervous system. Let's talk about alpha blockers and beta blockers. And beta blockers. Okay, so this is the first slide of the day. So let's start with alpha blockers and beta blockers. First, let's discuss or compare the differences between alpha blocker and beta blocker. What is the difference? Okay, so let's first compare the differences. Comparison. First point, if you remember, we have discussed that alpha receptor was present on blood vessel, which causes vasoconstriction. Don't draw this diagram. And beta 2 receptor was present on blood vessel, which causes vasodilatation. Do you agree? So if you will block alpha receptor, there is epinephrine in the blood. Epinephrine will act on beta receptor, and because of this reason there will be vasodilation. So alpha blockers are vasodilators. What about beta blocker? Beta blocker will be vasoconstrictors. Beta blocker will be vasoconstrictor. In bracket you will write except third generation. What do you mean by this word except third generation? We will discuss later on. Okay, there are certain generations. Second point, if you will dilate blood vessel, it will lead to, second point, reflex. It will lead to reflex bradycardia or tachycardia. Tell me if you remember your yesterday's class. It will lead to reflex tachycardia. So alpha blockers, they produce reflex tachycardia because of vasodilation. Now we know that our heart, it contains beta 1 receptor, and normally beta 1 receptor increases heart rate. So if you will give beta blockers, they will produce bradycardia. They will produce bradycardia. Why? Because they block beta 1 receptor on heart. Because they block beta 1 receptor on heart. Let's move ahead. Okay. Third point, we will write now that effect on different organs. Next point, we will write very simple point. Okay. Remember, if you will produce vasodilation, in corpus cavernosum, corpus cavernosum is a part of penile blood vessels. Because of this reason, there will be increase in blood flow to penile area. It will lead to increase in blood flow. Increase in blood flow can lead to prolonged penile erection, and this is known as priapism. It is known as priapism. Next point, With beta blocker, it will reduce, if you will produce vasoconstriction, it will decrease the blood supply to penile area. And if there is decrease in blood supply to corpus cavernosum, it will lead to erectile dysfunction. It will lead to erectile dysfunction, which is known as impotence. Which is known as impotence. Okay? Which is known as impotence. So alpha blockers, they cause penile erection. Beta blockers, they cause impotence. Okay? Now can you tell me which generation of beta blocker will cause least impotence? Which generation of beta blocker will cause least chances of impotence? Your answer should be, this is the beta first slide. Your answer should be, the beta blocker which will cause least chance of impotence will be third generation beta blockers. Why? Because third generation beta blockers are not vasoconstrictors. Okay? Next point. Can we use alpha blocker for the treatment of impotence? That point I will tell you later on. Okay? Fourth. Very good. Fourth point we will write now. Now, suppose this is beta cell of pancreas. This is suppose pancreas. Now remember, in pancreas, alpha 2A and alpha 2B both, they inhibit insulin release. They inhibit insulin release from pancreas, and beta 2 receptor, it promote insulin release from pancreas. It promotes insulin release from pancreas normally. So if you will give alpha blocker, can we say there will be unopposed beta action? They will promote insulin release. Because of this reason, alpha blocker, they are good for diabetes mellitus. Alpha blockers, they are good for diabetes mellitus, and beta blockers, they are bad for diabetes mellitus. Beta blockers are bad for diabetes mellitus. Leave beta one page only. Okay. Similarly, we will write that alpha blockers are good for dyslipidemia. Dyslipidemia means when the bad lipid level in our body increases. Why? Because it decreases the bad lipid level. Those bad lipid level is, you will write LDL and triglycerides. They decreases bad lipid level and it increases a good lipid level from liver, HDL. It increases a good lipid level, HDL, from the liver. It's a direct action on liver. And you will write beta blockers are bad for dyslipidemia. Why? Because it increases LDL and triglyceride, which are bad, and it decreases HDL level, which is good. Okay, this is the direct action of alpha blocker and beta blocker on liver. Okay, direct action on liver. Okay, now you will write one exception to it. You'll write one exception to it. Except bucindolol, except bucindolol. Bucindolol is a beta blocker. Bucindolol, sorry, just a moment. Bucindolol is a beta blocker with alpha blocking action, and this beta blocker increases HDL level. This beta blocker increases HDL level. Okay? HDL level. This is one exception you just remember for a moment. Okay? Why is it so? We will discuss later. Okay? Why is it so? We will discuss later. Okay? Yes, alpha 2C also. You are absolutely right. Alpha 2C also. Okay? You're right. Now, let's start keeping these things in mind. The comparison. Let's talk about alpha blocker. See, pancreas, they have both alpha receptor and beta receptor. Alpha inhibit insulin release, beta promote insulin release. If you will give alpha blocker, insulin will release more, which is a good thing in diabetic person. Okay. So how we can remember? You can write alpha R अच्छे, or you'll write alpha R अच्छे for diabetes and dyslipidemia, and you will write beta R bad for diabetes and dyslipidemia. Alpha R अच्छे for diabetes and dyslipidemia, beta R bad for diabetes and dyslipidemia. Okay? Chaliye, let's keeping this thing in mind. Let's start with first one, alpha blockers. Let's start with the first class of drug, that is alpha blockers. Make a heading everyone, alpha blockers. Now we will write that alpha blockers are of three types. Alpha blockers are of three types. Okay. Now you will write non-selective alpha blocker. I will take all your doubts later on. Just first write non-selective alpha blockers. It means they block both alpha 1 as well as alpha 2. Okay. Second, selective alpha 1 blocker, and similarly alpha 2 blocker. Similarly alpha 2 blockers. Simple. Let's first talk about non-selective alpha blockers. Let's first talk about non-selective alpha blockers. Okay. So non-selective alpha blocker, they are further divided into two types. They are further divided into two types. First one you will write non-competitive plus irreversible blocker. Non-competitive plus irreversible blocker. And second one you will write is competitive plus reversible blocker. Competitive plus reversible blocker. Okay. Non-competitive plus irreversible, competitive plus reversible. Now there is only one drug we have among non-competitive reversible blocker. There is only one drug. That drug name you will write is very important for you. Phenoxy benzamine. Phenoxy benzamine. This is a very important point. Phenoxy benzamine. Simran Sarthi, both beta blocker and beta agonist, they both produce hyperglycemia through different action. Simran, they both produce hyperglycemia. Okay. Now, phenoxybenzamine. Let's talk about this phenoxybenzamine. This phenoxybenzamine is given as an IV drug. Okay. And it is the drug of choice to control symptoms of pheochromocytoma. Can you tell me the most common symptom of pheochromocytoma tumor? The most common symptom of pheochromocytoma tumor is hypertension. Okay. Now, remember one point. What happens in pheochromocytoma? Very large amount of catecholamines like epinephrine, norepinephrine, they come into the blood. When this large amount of epinephrine, norepinephrine come into the blood, they act on alpha receptors and they produce hypertension. Okay. Now, remember one point. If you will give irreversible blocker, what do you think? That high level of epinephrine will able to overcome the effect of phenoxybenzamine? Will high level of epinephrine can overcome or they can displace phenoxybenzamine from the receptors? The answer is no. That is why phenoxybenzamine is the drug of choice for pheochromocytoma, because high level of catecholamines cannot displace phenoxybenzamine. Okay. So this is the reason. Irreversible, you cannot remove from receptors. Very good. Now, remember one point, that when you give phenoxybenzamine for pheochromocytoma, in the treatment of pheochromocytoma, first we give alpha blocker, that is phenoxybenzamine. And then we add beta blocker. That beta blocker which we add is propranolol. So first we give beta blocker and then we add, followed by second drug we add is propranolol. Okay. My question from you is, that can we reverse this thing? Can we give first beta blocker then alpha blocker? The answer is no. First alpha, let the effect of alpha blocker should come, then you will add beta blocker. Because if you will first add beta blocker, can we say what will happen to blood pressure? If you will add first beta blocker, alpha receptors are free, epinephrine will act on alpha receptors and the blood pressure will shoot up. Okay, the blood vasomotor reversal and re-reversal will come out here. Okay, so first you add alpha blocker, then you will add beta blocker. Now the point is, why we add beta blocker? We add beta blocker to control tachycardia. Don't you think alpha blocker, they produce reflex tachycardia? Yes. Don't you think alpha blockers, they produce tachycardias? To control this tachycardia, then we will add beta blocker. Okay. So phenoxybenzamine will act on, is a drug of choice to control the symptoms of pheochromocytoma. In earlier class, I also told you one drug, metyrosine. Metyrosine inhibit the production of catecholamine. It is given when you cannot do surgery in your patient. Now let's talk about competitive and reversible blocker. Competitive and reversible blocker, I am writing here. You can write below phenoxybenzamine. Okay, you can write below phenoxybenzamine. So first, competitive reversible blocker, I am writing here. You can continue below phenoxybenzamine. So the first drug among competitive reversible blocker is phentolamine. Leave four lines. Leave four lines below phentolamine. Then write tolazolene. And third, you will write one antipsychotic drug, chlorpromazine. You'll write in bracket, it's an antipsychotic. I told you this drug in amphetamine poisoning. And the fourth drug you will write is ergots, like ergotamine. Fourth drug you will write ergotamine. Okay. Fourth drug you will write ergotamine. Done? Now, let's talk about first phentolamine. Let's first talk about phentolamine. Now, phentolamine. Phentolamine is given IV and it is the drug of choice for cheese reaction, I hope I have told you this part. Second, it is the drug of choice for clonidine withdrawal. It is the drug of choice for clonidine withdrawal. Next, it is given as a injection in corpus cavernosum. It is given as an injection directly into corpus cavernosum for the treatment of impotence. Can you tell me the reason why? Impotence, because it causes prolonged penile erection. Hence, it is given for the treatment of impotence. And lastly, it is given to control hypertension during surgery in pheochromocytoma. So during surgery, because of rapid action and reversible action, we can use phentolamine to control hypertension during pheochromocytoma, during surgery of pheochromocytoma. But if a question comes, the drug of choice for pheochromocytoma is phenoxybenzamine. Okay, phenoxybenzamine. Tolazolene is the drug of choice in angiography procedure. It is the drug of choice during angiography procedure. Why? Because in angiography what happens, you put a dye. I'll repeat again. Tolazolene is a drug of choice during angiography procedure because during angiography procedure you put a dye and that dye can lead to vasospasm. Hence, to prevent vasospasm, we give tolazolene. To prevent vasospasm, we give tolazolene. Can you tell me certain angiographies where we do angiographies? Coronary angiography, digital angiography, etc. Okay. So these are the uses. These drugs you don't have to remember. So last two drugs you don't have to remember. Just one additional point, you will write ergotamine is an alpha blocker with vasoconstricting property. Question come, which alpha blocker is not a vasodilator, rather a vasoconstrictor is ergotamine. The reason is ergotamine stimulate 5-HT2 receptor. 5-HT2 stand for serotonin. Because of serotonin stimulation, it rather produces vasoconstriction. So this is a very important slide for you. Okay. Yes. So ergotamine is a vasoconstrictor. So which alpha blocker is a vasoconstrictor? Ergotamine. Okay. So this completes our non-selective alpha blocker. Let's come to now selective alpha 1 blocker. Yes, ergotamine is absolute. You're absolutely right, Partha, that ergotamine is used in migraine. Because of its vasoconstrictive property, we give in migraine. Okay. Chaliye, let's come to now selective alpha 1 blocker. Let's come to now selective alpha 1 blocker. Very simple. First, I will tell you the concept. Of alpha blocker. Just remember where alpha 1 receptor were present. Alpha 1 receptor were of two types, if you remember. Alpha 1A, which is also known as alpha 1D, and alpha 1B. Okay. If you remember that alpha 1A receptor contract IUS. If you remember, alpha 1A receptor contract or closes internal urethric sphincter. Okay. Internal urethric sphincter. And alpha 1B causes vasoconstriction, and vasoconstriction increases blood pressure. Vasoconstriction will increase blood pressure. We know this part. So if you talk about alpha 1 blocker, can we say that alpha 1 blocker will block this action? So can we say it will open internal urethric sphincter? I hope you remember internal urethric sphincter. It was present below the bladder. I hope you remember internal urethric sphincter. So here alpha 1A receptor were present. Now remember, when you want to open internal urethric sphincter, when this sphincter was closed, what closes this sphincter? Remember, behind this sphincter, there is a gland. Which gland is present behind this sphincter? Prostate. If the size of prostate increases, which in a condition known as BPH, full form I will tell you later on, benign prostate hypertrophy. In benign prostate hypertrophy, there is closure of IUS. In benign prostate hypertrophy, there is closure of IUS. Hence, you want to open it. So, alpha blocker, they are used in BPH. They are used in BPH, benign prostate hypertrophy. Now again, if you will give an alpha blocker, they will produce vasodilation. Vasodilation will decrease blood pressure. Hence, they are used in the treatment of hypertension. Hence, they are used in the treatment of hypertension. So, these are the two uses of alpha 1 blocker. Okay. It is benign prostatic hypertrophy. Okay. There is more of hypertrophy, less of hyperplasia. Okay. Some books mention it hyperplasia also. You can write anything. Okay. Now, let's write certain drugs. So the first drug you will write is selective alpha 1 blocker. And these drugs, they will end with the word zoosin. These drugs, they will end with the word zoosin. Can you tell me certain drug? First is prazosin, terazosin, elfuzosin, doxazosin, and doxazosin. Simple. And doxazosin. Okay. Yes. Very good. Simple to remember. Now, first we will write that this prazosin, it is the drug of choice. It is the drug of choice for BPH with hypertension. If a patient of benign prostatic hypertrophy comes with hypertension, you give this drug. Okay. Second point, we will write that this terazosin and this doxazosin, these two drugs, they have additional apoptotic activity on prostate. That means they can decrease the size of prostate also. They can decrease the size of prostate also. Okay. Second point, I will tell you later on that these drugs you will write have good, they are good for diabetes and dyslipidemia. They are good for diabetes and dyslipidemia. With prazosin, you will write prazosin is also the drug of choice for hypertension and pulmonary edema. Pulmonary edema due to scorpion sting. Due to scorpion sting. You know what is scorpion sting? In scorpion sting, what happens? There is increase in sympathetic activity. So prazosin is also the drug of choice for hypertension and pulmonary edema because of scorpion sting. Okay. DM beta stands for diabetes mellitus. Okay. Now let's talk about their side effect. Okay. Chalo, before coming to side effect, now let's write alpha 1A blocker. Alpha 1A blocker. Can you tell me that alpha 1A blocker will only act on internal urethric sphincter? It will only act on internal urethric sphincter. Do you agree with this part? And these drugs, they end with the word osin. Z will not come. Z word will not come. So the drug is tamsulosin and silodosin. Tamsulosin, silodosin. Okay. So Z word will not come out here. Can we say that they will dilate only IUS? Okay. They have no effect on blood pressure. They have no effect on blood pressure. Do you agree with this part? Hence, these drugs are known as uroselective alpha blocker. These drugs are known as uroselective alpha blocker, and this tamsulosin is considered as a drug of choice for BPH. This tamsulosin is considered as a drug of choice for BPH. Now my question from you is, if I will ask you the question before going further, drug of choice for BPH, what will be your answer? And second question, drug of choice for BPH with hypertension. Drug of choice for BPH and drug of choice for BPH with hypertension. Answer, tell me the answer. We are coming to Iris beta. Drug of choice for BPH is tamsulosin. And drug of choice for BPH with hypertension is prazosin. Most commonly used drug is this one. I hope you have understood the concept. I hope you have understood the concept. Now tell me, which drug will cause hypotension? Which drug will cause hypotension as a side effect? The drug which causes hypotension as a side effect is prazosin. Okay, so let's write the side effects of prazosin. Prazosin is an important drug for you. So just writing the side effect of prazosin. Okay, so the first side effect of prazosin is, you will write postural hypotension. What happens in postural hypotension? It's very simple. When you stand up, your leg veins should constrict so that blood can move upwards. Now if you will stand up, the blood vessels are blocked by alpha receptor. The blood vessel will not constrict, it will remain dilated. The blood will not move upwards toward the heart and brain. The blood pressure will fall down. Hence it is known as postural hypotension. It is known as postural hypotension. Okay. Now, this postural hypotension due to prazosin is known as first dose effect. Why? It is known as first dose effect because it is seen on start of therapy, or you will write first dose. It shows maximum. Maximum hypotension is seen when we start prazosin, later body adapts. Okay. So question comes, how to manage postural hypotension? How to manage postural hypotension with prazosin? Very simple. Okay. Now, first you will write start with low dose. Start with low dose and give the dose at bedtime. Why bedtime? Before sleeping, why bedtime? because person will eat and person will lie down. Person doesn't have to stand up. Okay, that man doesn't have to stand up. So generally we start with 0.5 milligram HS. HS stands for before going into sleep, and then we gradually increase to 4 milligram HS. Okay, we give HS means bedtime. HS means bedtime. And if you want to treat, the drug of choice for the treatment of postural hypotension is midodrine. The drug of choice for the treatment of postural hypotension is midodrine. Okay? Midodrine. I hope it's simple now. Next point you will write that prazosin causes priapism. And third, it causes mydriasis. Mydriasis will not happen. Okay, so you will write one side effect known as floppy iris syndrome. Floppy iris syndrome is, you will write no mydriasis. No mydriasis. The iris will remain dead or miotic and it will be floating in aqueous humor. Floppy iris syndrome matlab paralyzed iris. Because mydriasis is not happening, iris will remain paralyzed. Okay. So these are the side effects of prazosin. Now, before going further, let's see the treatment of BPH. Let's see the treatment of BPH. Benign prostate hypertrophy. Benign prostate hypertrophy. Treatment of BPH. Now, what is the problem in BPH? We all know that this is the bladder. In bladder, there are two things happening. One, there is increase in size of prostate. And that increase in size of prostate is closing IUS. It is closing IUS. So we have two options for the treatment. The first option is open IUS. First treatment of BPH is open internal urethric sphincter. Open internal urethric sphincter. And second is decrease the size of prostate. Decrease the size of prostate. Okay, these two things we have to do. When you open IUS, it is known as treatment of dynamic component. And when you decrease the size of prostate, it is known as treatment of static component. What is dynamic and static component? You will learn in surgery, not a part of pharma. Okay. Now to open IUS, you will write, now to open IUS, you will write the drug of choice is tamsulosin. Drug of choice to open IUS is tamsulosin. But if the patient is having hypertension, you can start prazosin. You can start prazosin. Now, think logically and tell me. You know that below this sphincter, below this internal urethric sphincter, there is opening of seminal ducts. Below this sphincter, there is opening of seminal duct. So if you will open this sphincter, What will happen to ejaculation? What will happen to ejaculation? These drugs in BPH, their side effect is retrograde ejaculation. These drugs, their side effect is retrograde ejaculation. Okay, tamsulosin is beta 5 alpha 1A, alpha 1A. Okay, so it will lead to retrograde ejaculation. I hope it's clear to you. Okay, now to decrease the size of prostate, we give a drug, you will write 5 alpha reductase inhibitor. We give a drug 5 alpha reductase inhibitor. Okay, 5 alpha. See, tamsulosin is beta 5 alpha 1A blocker. Prazosin is alpha 1 blocker. Okay, we already know this part. We have discussed it. Okay, we have discussed this. Now, to reduce the size of prostate, we give 5 alpha reductase inhibitor. Now, what do you mean by the word 5 alpha reductase? Let's understand this part. You know that in body there is a hormone testosterone. There is a hormone testosterone, but the more active form of testosterone is dihydrotestosterone. Reductase means addition of hydrogen. Dihydrotestosterone. Remember, this dihydrotestosterone, it increases secondary sexual characters. The secondary sexual characters, they come because of dihydrotestosterone. Now, what are those secondary sexual characters? Very simple. Those secondary sexual characters are prostate growth, okay, alopecia. In males, there is alopecia. And third, facial hair growth. Facial hair growth. So male-like characters is because of dihydrotestosterone. So 5 alpha reductase inhibitor, they will inhibit this part. So 5 alpha reductase inhibitor, they inhibit conversion of dihydrotestosterone into dihydrotestosterone. So what are these drugs? The drug name you will write are, the drugs are two drugs, finasteride and dutasteride. Finasteride and dutasteride. Alopecia beta means loss of hair. Alopecia, you know that males with age they become alopecia, there is loss of hair. Baldness, you also call it as baldness. Okay, so where finasteride is used, finasteride and dutasteride, they are given to for the treatment of BPH for male pattern alopecia. Male pattern alopecia. Now, can you tell me, when facial hair growth occurs in females, it is unacceptable? That facial hair growth when occurs in female, it is known as hirsutism. It is known as hirsutism. So these drugs are also given for the treatment of hirsutism also. Okay. So in alopecia, you are absolutely right, beta. Nikhil Basin. There are two drugs which are approved for alopecia. One is minoxidil, second is finasteride and dutasteride. Okay, and that we will discuss later. Recently, it has been approved for, you will write, prostate cancer as well. So these are the uses of these drugs. because prostate is a gland which is dependent upon dihydrotestosterone for its growth. Okay, cancer, hypertrophy, they all are dihydrotestosterone dependent. Okay, so this is the treatment of BPH. Now let's summarize again treatment of BPH. So open IUS, to open IUS, which drug we give? To open internal urethric sphincter, we give alpha-1 blocker or alpha-1A blocker. Their side effect is when sphincter opens, there will be retrograde ejaculation. And to decrease the size of prostate, you give 5-alpha reductase inhibitor. And these drugs are finasteride and dutasteride. And they have other uses as well. In females, if there is increase in testosterone level, there are certain areas in females also where testosterone is produced, like ovaries, adrenal, etc. So females may have high level of testosterone, which can lead to hirsutism, which is unacceptable in female. Okay, unacceptable in female. Okay. Now let's move ahead. The last drug you will write is alpha-2 blocker. The last drug we will write is alpha-2 blocker. You'll write first the list of the drug. Yohimbine. Okay. Second, idoxazan and certain antidepressant which we will discuss in CNS, like mirtazapine. So try to remember these two names. Mirtazapine I will be telling you in when we will discuss CNS. Okay, when we will discuss CNS. So alpha-2 blocker, yohimbine, idoxazan. Try to remember these two words. Now yohimbine. You'll write yohimbine. It is used to increase libido. Yohimbine is used to increase libido. Libido means sexual performance. Why? Because it produces prolonged penile erection. Okay? And any drug which increases sexual performance or libido is an aphrodisiac. It's a plant product. Some people, they eat this plant to improve their sexual life. Okay, but remember this yohimbine, 2 point we will write, is not approved drug. Yohimbine is not an approved drug. Second point, yohimbine is an alpha-2 plus 5-HT2 blocker. It also has 5-HT2 blocking property. Okay, just write these 2 points. Yohimbine is an important drug for you. Question comes very commonly on yohimbine. Okay, so drug of choice for to produce penile erection is sildenafil. You are absolutely right. Viagra. It is a very old drug. Certain cultures or tribal people, they eat this plant actually. Okay, yohimbine plant. Other two drugs you don't have to remember. Nothing. Don't have to remember. Idoxazan is not approved. Mirtazapine we will discuss in depression. So this completes our alpha blocker. Okay. Aphrodisiac means the drug which is used to increase sexual performance. Okay. We don't want to approve. Already we have a lot of population. So don't approve any aphrodisiac for a moment. Okay, chalo. Let's start with now. Next point. Let's talk now with beta blockers. Okay, beta blockers. Clonidine beta we have discussed yesterday. Yes, Shilajit is also there. Yes, okay. So you have a lot of knowledge. So let's first talk about the classification of beta blockers. Let's talk about classification. Maximum question comes on classification of beta blocker and students have a lot of doubt. Okay. So let's simplify the things now. Okay. Let's classify beta blockers. Now beta blockers, you will write, they are of three types. They are of three types. You'll write first generation beta blocker, first generation beta blocker, second generation beta blocker, and third generation beta blocker. Third generation beta blocker. Okay. Now, first generation beta blocker, you will write that they are non-selective beta blocker. Non-selective means they will block beta 1, beta 2 and beta 3 equally. They will block all beta 1, beta 2 and beta 3 equally. Second generation, they are known as cardioselective beta blockers. Can you tell me they will be blocking which receptor mainly? Which receptor is mainly present on heart? They will mainly block beta 1, less of beta 2 and beta 3. They will mainly block beta 1, less of beta 2 and beta 3. Okay, less of beta 2 and beta 3. Now, one question I want to ask you. Sir, that if you will block beta 2, if you will block beta 2 on blood vessels, what will happen? Vasodilation or vasoconstriction? If you will block beta 2 on blood vessel, it will lead to vasoconstriction. It will lead to vasoconstriction. Do you agree with this part? Okay, it will lead to vasoconstriction. Hence, now we have third generation of beta blockers. Third generation of beta blockers, they have some additional property. Due to that additional property, they are vasodilators. They are vasodilators. Okay, so third generation beta blocker, they have some additional property. Due to that additional property, they are vasodilator. They are vasodilator. Just a moment, let me refresh it. Okay. Now, what additional property? I will tell you shortly. In a 2 minutes time, I will tell you. So first, let's write the names of those beta blocker. Okay. First, let's write the names of those beta blocker. So you will write that in first generation, any beta blocker which start from the word P will be first generation. And you will write TNS. So you will write propranolol. The first beta blocker we made was propranolol, penbutolol, pindolol, timolol, nadolol, and sotalol. And sotalol. Okay? Sotalol. Here you will write a mnemonic. Beam. Here you will write a mnemonic. Among cardioselective, you will write a mnemonic beam. Okay? You will write a mnemonic beam. So B for you will write bisoprolol. E for ismolol. A for atenolol. A for acebutolol. And M for metoprolol. M for metoprolol. Just a moment, I'll give you a break, don't worry. Okay. Now, third generation beta blocker. You'll write third generation beta blocker, they are vasodilator, that we know. They are vasodilator. But what vasodilatory action do they have? Before coming to that, you'll write that third generation can be non-selective. They can be cardioselective. Third generation can be non-selective and cardioselective, but how they are different from first and second? They are vasodilator. Okay. So among non-selective, you will write cartiolol, celiprolol, labetalol, and bucindolol. Among them, try to remember these two. Try to remember these two, they are commonly asked. Okay. So among third generation, you have to remember celiprolol and labetalol. And here you will write nebivolol, betaxolol, and carvedilol. You have to remember these three drugs. The list is very large. You don't have to remember the huge list. Okay. So nebivolol, betaxolol, and carvedilol. It is coming. Okay. Nebivolol, betaxolol, and carvedilol. Okay. So the drugs I have shaded, you have to remember. And these all drugs you have to remember. These all drugs you have to remember. The drugs I have shaded, you have to remember them. Okay. Now, second point arises, why third generation beta blocker have vasodilatory property? So let's write about vasodilatory property of third generation beta blocker. Vasodilatory property of third generation beta blocker. Third generation vasodilatory action. Vasodilatory action. Very simple to remember. Let's see how do they produce vasodilatation. We'll make a chart. We'll make a chart. Okay. And we will write 1, 2, 3, 4, and 5. You'll write 5 points. Okay. First one, certain beta blocker, they increase nitric oxide production. Certain beta blocker, they increase nitric oxide production. And you know that nitric oxide causes vasodilation. Okay. Second point, Second point, you will write certain beta blocker, they are rather beta 2 agonist. They are rather beta 2 agonist. Instead of blocker, they are stimulator of beta 2, and beta 2 receptor produces vasodilatation. Certain beta blocker, they are calcium blocker. You know that calcium is required for muscle contraction. So calcium causes vasoconstriction. Okay. Then certain beta blocker are also alpha 1 blocker. You know that alpha receptor causes vasoconstriction. And lastly, certain beta blocker, they are potassium channel opener. Because if potassium channel will open, potassium channel opener. Because if potassium channel will open, the potassium will move out of the muscles. Muscle will become hyperpolarized and blood vessels will dilate. Okay. So these are the actions. These are the actions. Okay. So these are the 5 actions we have learned. Let's write the names of those drugs. Okay. Very easy to remember. Here you will write nebivolol, and nipradilol. Now please mark this word nebivolol. It is commonly asked. Second point, you will write both action. Both action. Second point, you will write both action. That means, just a moment. Yeah, both action. Both nitric oxide and beta 2 agonist property, you will write celiprolol. Celiprolol. Please mark it, commonly asked question. Okay. Celiprolol. Done. Calcium channel blocker. See, the list is very big. You cannot remember full list. The names you have to remember, I'm just writing them. Okay. Now, next point, calcium blocker. You will write one very important drug for you. And that drug you will never forget is betaxolol. Very important. Betaxolol. Don't forget this point. Then we will write among alpha blocker, very important drug, labetalol. Okay. Bucindolol. Bucindolol. And again nipradilol. And don't forget this alpha 1 blocker, that is labetalol, very commonly asked question. Okay, you have to remember labetalol. Now here you will write there are certain drugs which have both action. There are certain drugs which will have both action. Okay, just for a moment. There are certain drugs which will have both action. That drug you will write is carvedilol. Carvedilol, bivantolol, and don't forget this carvedilol. Don't forget this carvedilol. And the last drug you will write is tilisolol. Last drug we will write is tilisolol. Okay. Last drug is tilisolol. Now I want to ask you one question. One question which comes very commonly. Tell me the answer. Which of the following drugs are known as combined alpha plus beta blocker? Which of the following drugs are known as combined alpha and beta blockers? Can we say that these drugs are combined alpha and beta blockers? These drugs are combined alpha and beta blocker, and you have to remember two names. One, labetalol, and second drug you have to remember is carvedilol. Second drug you have to remember is carvedilol. I hope you have understood. Okay, I hope you have understood. And the last point here only we will write about carvedilol. Carvedilol is a beta blocker. Why it is a beta blocker? Because all beta blocker they end with the word LOL, lol. Okay, so it's a beta blocker. Carvedilol is a beta blocker with three property. CAR. Okay, so carvedilol is a beta blocker with the three property CAR. The first is it is also a calcium blocker. Okay, then alpha 1 blocker, and third you will write it reduces oxidative stress. That means it has antioxidant action. It has antioxidant action. So you can remember R word. CAR, car word. Okay. So let's take a 2 minutes break. Yes, LOL, lol. All beta blocker they end with the word lol. Facebook wala lol. Lots of love. Okay. So we are taking 2 minutes break. Not 5 minutes, 2 minutes break. So welcome back everyone. So let's write now the properties of beta blocker. Okay. Properties of beta blocker. First point you will write longest acting beta blocker. Very commonly asked question. And shortest acting beta blocker. Okay. Okay. So longest acting beta blocker you will write is nadolol. Very commonly asked question. And shortest acting beta blocker you will write is ismolol. The shortest acting beta blocker is ismolol. Question comes, why ismolol is the shortest acting beta blocker? Because when you give ismolol to your patient, it is rapidly metabolized in plasma. Ismolol is rapidly metabolized in plasma. By which enzyme? It is rapidly metabolized in plasma by esterase enzyme. Okay. So we'll write by. So I'm just writing there. Just Okay, so why? You will write because it is rapidly metabolized in plasma by an enzyme known as esterase enzyme. Okay, esterase enzyme. E for small, E for esterase enzyme. Now let's move ahead. Second point you will write. Second point you will write that second point we will write that all beta blockers are racemic mixture. All beta blockers are racemic mixture of R form plus S form. And you will write except timolol, only S form. Except timolol, only S form. Okay. Third point. We will write that beta blockers are metabolized by CYP2D6. What is CYP2D6? We will see later on. And CYP3A4. What is this CYP2D6, CYP3A4? We will learn it later on. Okay? Later on. You know what is racemic mixture from 11th and 12th you have learned. R form, S form. Okay, dextro, levorotatory forms, you know. Now, let's move ahead. Tell me, I want to ask you one question and tell me the answer. Which beta blocker open potassium channel? Which beta blocker open potassium channel? The answer was tilisolol. This we already know. But you will write which beta blocker will close potassium channel. And a very important drug, sotalol. Very important drug, sotalol. Okay. And last property of beta blocker, we will write that beta blockers, they are metabolized in liver by CYP enzymes. We have written above CYP enzymes. Certain beta blockers, they are metabolized in liver by CYP enzymes. Why? Because beta blockers are lipid soluble, and lipid soluble drug is metabolized in liver by CYP enzyme so that they get converted into water soluble form and they should be excreted. You will write now except NASA. First, what do you mean by this word? First, you will write the name of the drug, nadolol, atenolol, sotalol, and S-butolol. S-butolol. This is a very important part. Question comes very commonly. You will write that these drugs, they are water soluble. These beta blockers are water soluble. They are not metabolized in liver. They are not metabolized in liver. And if they are water soluble, they are excreted out of the body. They are excreted unchanged because they are not metabolized in urine. These beta blockers are excreted unchanged in urine. So my question from you is, can we say that these 4 beta blockers, they are safe in liver failure? These 4 beta blockers are safe in liver failure. Why? The answer you will write is, they are not metabolized by CYP enzyme in liver, but these beta blockers, they are absolutely contraindicated in renal failure. I hope you have understood the concept. So these 4 beta blocker NASA, NASA, they should not be given in renal failure. This is a very commonly asked question. Okay? These beta blockers are contraindicated in renal failure. They are NASA. Okay? Now, let's talk about, let's see, one student has asked me a question. Ismolol is not metabolized in liver. You are absolutely right. Ismolol is metabolized by esterase enzyme. But my question is, these plasma enzymes like esterase, who forms this enzyme? Who synthesizes this enzyme in plasma? This esterase enzymes which is coming in plasma are synthesized by liver only. Okay? They are synthesized by the liver only. So ismolol is also contraindicated in liver failure. Okay? Now let's move ahead. Let's talk about now the uses of beta blockers. Uses of beta blockers. Now the uses are very simple. We will divide the uses into 2 types. First, you will write uses in which you want to block beta 1 only. My question is, there are certain diseases in which you want to block only which receptor? Beta 1 receptor. Now tell me, which beta blocker would you like to use? Cardioselective or non-selective? If you want to block beta 1 only, which beta blocker will you love to use? Cardioselective or non-selective? What is your answer? The answer is, we will use cardioselective beta blocker. If you want to block beta blockers, a beta 1 receptor only, you will prefer to use cardioselective beta blocker. Okay, so let's see where beta 1 receptor were present. Beta 1 receptor were present in 2 areas. It was present on heart and it was present on JG cells of kidney. And in JG cells of kidney, they will decrease renin release. And in heart, they will also decrease the activity of the heart. And you know that RAS system, renin, angiotensin, aldosterone system increases blood pressure in our body. Hence, beta blockers, they are given for the treatment of hypertension. Question comes, why beta blockers, they are used in the treatment of hypertension? Because beta blockers, they decrease the renin release from the kidney, and decrease in renin release decreases blood pressure, because RAS system is the main system in the body which increases our blood pressure for very long term. Okay? Now, in heart, you will write, they are given in all cardiac diseases. Beta blockers are given in all types of cardiac diseases, except I will tell you shortly. So you name any heart disease, beta blockers are used there. But there are only 2-3 heart disease where you will not use beta blocker. Okay, so keeping this thing in mind, let's write any heart disease which comes into your mind. Beta blockers, they are the drug of choice for MI, myocardial infarction. Second, stable angina. They are the drug of choice for stable angina. Third, they are used in tachyarrhythmias. They are used in tachyarrhythmias because they will decrease heart rate. Fourth, you will write they are given in CHF. CHF stands for chronic heart failure or congestive heart failure. Chronic heart failure. Okay. Then any other heart disease, yes, you will write beta blockers are the drug of choice for HOCM. They are the drug of choice for HOCM, hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. Okay. Then you will write tetralogy of Fallot. Tetralogy of Fallot. What is that? You will learn in pediatrics. Now, beta blockers, why they are given in heart failure? Because beta blockers, they decrease remodeling of heart. What is that? We will discuss in CVS. And why it is given in hypertrophic obstructive cardiomyopathy? Because it will decrease hypertrophy. Because heart does not have to beat much now. Slowly and slowly the hypertrophy of the heart will reduce. Slowly and slowly the hypertrophy of the heart will reduce. And the last point you will write aortic dissection. Aortic dissection. So these are the uses. You name any heart disease, blindly mark the answer beta blocker. But let's see what are the contraindications of beta blocker in heart. So in which condition you will not give beta blocker? We know that beta blocker will decrease heart rate. So instead of tachyarrhythmia, you will never give beta blocker in bradyarrhythmias. You will never give beta blocker in bradyarrhythmia. Why? Because they suppress heart. Okay. So can you tell me some causes of bradyarrhythmia? When SA node is defective, can we call that syndrome as sick sinus syndrome? Sick sinus syndrome, what happens? SA node is defective, heart rate is very less. Similarly, you will write below SA node there is AV node. So there is AV node blockage. Remember, don't give beta blocker, they reduce the conduction from AV node as well. So when the heart is beating more, give beta blocker, but when the heart is beating less, don't give beta blocker. Second point, stable angina. Here you will write it is contraindicated in vasospastic angina. Beta blockers are contraindicated in vasospastic angina. Why? Because beta blockers, they themselves causes vasoconstriction of coronary artery. Beta blockers, they increase or they produce vasoconstriction of coronary artery. And here we have written chronic heart failure. You'll write beta blockers are contraindicated in acute heart failure. Why acute heart failure? Because they decrease cardiac output. Because they inhibit contractility of the heart. Contractility of the heart. So they should not be given in acute heart failure. Now tell me, think about what was the drug of choice for acute heart failure? Was it beta blocker or beta agonist? In acute heart failure, we were giving beta agonist like dobutamine, norepinephrine, etc. So in acute heart failure, we don't give beta blocker, we give beta agonist. Okay, beta agonist. So remember this part. Okay, so these are the uses of beta blockers and these are the contraindications of beta blocker. Very important for you. Very important for you. Okay, now second point I want to ask you. Second point is when you want to block beta 2 also. When you want to block beta 2 also. If you, beta Muhammad Rabi, how it causes vasoconstriction of coronary artery. I hope you remember blood vessels. Alpha causes constriction, beta causes dilatation. If you will give beta blocker are vasoconstrictors. We have already discussed. Okay? Beta blocker, they produce vasoconstriction. Okay? Vasomotor re-reversal of Dale, hai na, we discussed. Now, tell me, if you want to block beta 2 also, which beta blocker would you like to use? Cardioselective or non-selective? Cardioselective or non-selective in this case? Okay. Now, if you want to block beta 2 also, beta 1 as well as beta 2, here you will love to use non-selective beta blockers. Non-selective beta blockers. So first let's see the uses and then I will tell you the drug of choice. Okay. First let's see the uses. You will write a mnemonic 4P heat. And lastly write one molecule G. 4P. First point. First, beta blockers are the drug of choice to control symptoms of pheochromocytoma. Remember, after phenoxybenzamine, we were giving one drug, pheochromocytoma. Next P you will write, beta blockers are the drug of choice for prophylaxis of migraine. Beta blocker are the drug of choice for prevention of migraine. Remember, in migraine there is vasodilatation. When you will block beta 2, it will lead to vasoconstriction. It will lead to vasoconstriction that has beneficial effect on migraine. We will discuss in migraine. Okay. Okay. So blockage of beta 2 causes beta vasoconstriction. Blockage of beta 2 causes vasoconstriction. Okay. Stimulation of beta 2 causes vasodilatation. Okay. No, celiprolol is not given in acute heart failure. Now, next point you will write. Next point you will write. They are given for performance anxiety. See what happens in anxiety. Suppose tomorrow you have an exam. You have palpitation. You have tremors. Tremor occurs because of beta 2. Palpitation occurs because of beta 1. You have to block both of them. Performance anxiety. Okay. Next you will write they are also given for portal hypertension, or you will write dilated esophageal varices. Dilated esophageal varices. Varices means dilated blood vessel. If you will give beta blocker, beta 2 will cause vasoconstriction and the vessels will collapse. Okay. So this is 4P. 4P, pheochromocytoma, prophylaxis of migraine, performance anxiety, portal hypertension. Let's come to heat. Can you tell me when blood vessel dilates on skin, we give beta blocker? You will write hemangioma. Because if you will block beta 2, there will be vasoconstriction. Okay? Okay? Vasoconstriction, hemangioma. E for essential tremors. Can you tell me tremors on skeletal muscles are because of which receptor? Beta 1 or beta 2? Tremors on skeletal muscles are because of which receptor? Beta 1 or beta 2? That is because of beta 2. So block beta 2. Okay? HEAT, heat. A for one anxiety-like situation, akathisia. What is akathisia? We will discuss in CNS. And lastly, you will write thyroid storm or thyroid tremors. Thyroid tremors. So this become heat. This become heat. Now only word remaining is G. G for you will write glaucoma. Because beta 2 blockage decrease aqueous production, which we will discuss tomorrow in glaucoma. It decreases aqueous production. Okay? 4P, heat. Beta Harshita, in pheochromocytoma, to prevent vasoconstriction, first we will add alpha blocker phenoxybenzamine. So vasoconstriction will not happen now. Okay? Vasoconstriction will not happen. Don't worry about vasoconstriction in pheochromocytoma. We have already given first alpha blocker, then we add a beta blocker. Now, what is the drug of choice for all these conditions? Except glaucoma. The drug of choice for all these conditions is propranolol. The drug of choice, just a moment. Now, the drug of choice for all these conditions, the drug of choice for all these conditions is propranolol. Okay, welcome back now. Let's continue. Let's continue now. Okay, let's continue. So, where propranolol is the drug of choice? 4P, heat. Propranolol is the drug of choice for 4P, heat. Okay? Hemangioma means dilated blood vessels. So, tell me where propranolol is not given. Where propranolol is not given. Propranolol is not given in glaucoma. I will tell you the reason why. Just write, because it causes corneal anesthesia. Just write this word. I will tell you later on what is corneal anesthesia. So propranolol is not given in which condition? Glaucoma. Rest everywhere. Propranolol is the drug of choice. Okay? Drug of choice is propranolol. Now let's write the last 2 points with beta blocker. Okay? First point, side effect of beta blocker. And last point will be special property of beta blocker. So let's talk about side effect of beta blockers. Very simple and very commonly asked question. Okay? Side effects of beta blocker. Okay? Side effects of beta blocker. Yes, propranolol is used. If you are having anxiety, take propranolol before exams. 40 milligram propranolol you can take and it will relieve your anxiety. Now, side effect of beta blocker, you know each and everything. Now tell me the answer. if you will block beta 1, if you will block beta 1 receptor, can we say on heart beta blocker will lead to bradycardia? And second thing you will write, they will lead to AV node block. So this is the first side effect of beta blocker, that if you will block beta 1 on heart, it will lead to bradycardia and AV node block. Agree? Now second point you will write that if you will block beta 2, I hope you remember beta 2 causes bronchodilation. Beta 2 causes bronchodilation. If you will block beta 2, it will lead to asthma. Or you can write COPD. Okay. So COPD is a disease. So I will tell you should not give beta blocker in COPD. Second point, beta blocker, if you will block beta 2, it will lead to vasoconstriction. If it will lead to vasoconstriction, now tell me, if there is already vasoconstriction in fingers, that disease is known as, if there is vasoconstriction in fingers, that disease is known as Raynaud's disease. Okay. Now, if there is vasoconstriction in coronary artery, which angina it will cause? If there is vasoconstriction in coronary artery, it will lead to vasospastic angina. So vasospastic angina is also known as Prinzmetal angina. It is also known as Prinzmetal angina. And if you will block beta 2, because of this reason, they are bad for diabetes and they are bad for dyslipidemia, which I think we have already discussed. They are bad for diabetes and dyslipidemia. Okay. Just one point we have left. Vasoconstriction can lead to impotence also. Erectile dysfunction we have discussed. Vasoconstriction in corpus cavernosum. Okay. Corpus cavernosum. Okay. Yes, beta, drug of choice for prophylaxis of migraine is propranolol. Yes, you are absolutely right. Okay. Ramkumar, you are absolutely right. Now, I hope you have understood this part. Now tell me the answer. Now tell me one answer. You will write that non-selective beta blocker. Below it you will write non-selective beta blocker. I'll write one example, propranolol. Non-selective beta blocker. If a patient of bradycardia comes to you, would you like to give propranolol to the patient? The answer is they are absolutely contraindicated. And if a patient of asthma, COPD, Raynaud's disease, diabetes comes to you, propranolol is absolutely contraindicated. So propranolol or non-selective beta blocker, they are contraindicated. They are contraindicated in all these conditions. In all these conditions. But if I'll ask you one question, that what about cardioselective beta blocker like atenolol, metoprolol? Cardioselective beta blocker, they block more of beta 1 as compared to beta 2. So in which condition cardioselective beta blockers are contraindicated? They are contraindicated. They are contraindicated in bradycardia and AV node block. But they can be given in asthma COPD, Raynaud's disease, diabetes and dyslipidemia, but with caution. So you have to monitor them. Can you tell me why with caution? Why with caution? Because they have a little bit of beta 2 blocking property. They have little bit of beta 2 blocking property. They are much safer than non-selective beta blocker as compared in cases of asthma, COPD, Raynaud's, diabetes. Okay. So tell me the advantage of cardioselective beta blocker over propranolol. Can we write this is their advantage? This is the advantage of cardioselective beta blocker over propranolol. Why? Because they are relatively safe in asthma, COPD, Raynaud's, diabetes, dyslipidemia. So this is the advantage of cardioselective beta blocker over non-selective beta blocker like propranolol. Sorry. Now, let's talk about the last point of the day. Last point of the day. Nee beta, you don't have to give in asthma, but patient may have asthma. Patient may have asthma. A heart disease patient can have asthma also. Okay. So, now last point we will write is special properties. Okay, before special property we will write. Before special property you'll write beta blocker in diabetes. You'll write beta blocker in diabetes. First point, beta blocker, they are bad for diabetes mellitus. They are bad for diabetes mellitus. Okay. Why? First point, you will write they produce hyperglycemia. Why? Because they inhibit insulin release. They produce hyperglycemia because insulin release was because of beta 2. Second point, they can also lead to hypoglycemia. Why? Because they inhibit glycogenolysis. They can also lead to hypoglycemia because they inhibit glycogenolysis. I hope you remember that part. And lastly, you will write a very important point that beta blocker, they mask the symptoms of hypoglycemia due to insulin. They mask the symptoms of hypoglycemia due to insulin. This is a very important part. And this property is known as hypoglycemic mask the symptoms. You will write unawareness. Unawareness. Okay. Unawareness. Now, below this mask the symptom, in bracket you will write except. Bracket you will write except. Now let's understand this part, a very interesting part to understand. Okay, very interesting part. I'm telling you, beta Akash, how it masks. See, let's understand. Suppose there is a patient of diabetes and that patient is taking insulin. That patient is taking insulin. Suppose there is a patient who is taking insulin. You know that insulin causes hypoglycemia. You know that insulin causes hypoglycemia. Can we say that if there is hypoglycemia, the brain will get less amount of glucose? The brain will get less amount of glucose. Okay. Now, as the brain will get less amount of glucose, don't you think it is an emergency? Don't you think it is an emergency? And in emergency, the brain starts which discharge? If there is emergency, the brain starts which discharge? Sympathetic or parasympathetic? The brain will start sympathetic discharge. Okay? The brain will start sympathetic discharge. The brain is not getting ample amount of glucose. It's a bad thing. Due to this sympathetic discharge, there will be sudden appearance of palpitations. Why palpitations? Beta 1. There will be sudden tremors. Beta 2. And there will be sweating. Can you tell me which nerves produce sweating? Which sympathetic nerve produce sweating? I have told you. Sympathetic cholinergic nerves. Now, these symptoms which appear suddenly act as a warning. This acts as a warning by brain. And because of this reason, the person will go and eat. The person will go to the kitchen and eat. So if a diabetic person has taken insulin and suddenly there is palpitations, tremors, etc., person will come to know that I am now suffering from hypoglycemia. This is the method by what our brain is telling us that yes sir, you moron, you fool, you are getting hypoglycemia, go and eat something. Okay, so the person will go and eat something. Now the point is, and this eating will cure hypoglycemia. So my question is, if the patient is eating beta blocker, if the patient is having beta blocker, these symptoms will not come. If these symptoms will not come, the person will not eat anything. And if the person will not eat anything, this hypoglycemia will become very long. Patient may die also. Hypoglycemia is a dangerous thing. So because of this reason, the person will not eat anything. Now let's understand this part. Can we say that beta blocker, they mask the symptoms of hypoglycemia due to insulin? This property is known as hypoglycemic unawareness. Now question is, which symptom is not masked? Tell me the answer. Which symptom is not masked by beta blocker? What is your answer? Which symptom of hypoglycemia is not masked by beta blocker? You'll write sweating. Sweating is not masked by beta blocker because sweating is not because of beta receptor. Sweating is because of sympathetic cholinergic nerves. Sweating is because of sympathetic cholinergic nerves. So this is the question very commonly asked. Okay, so give me last 5 minutes. That will finish our autonomic nervous system. Last point we will write is certain special properties of beta blocker. Last point is certain special properties of beta blocker. Okay, and you will write two special property that will finish our lecture. You'll write first is ISA. Second, you will write MSA. ISA stands for intrinsic sympathomimetic activity. Okay, intrinsic sympathomimetic activity. Now I will tell you what is MSA later on. Now intrinsic sympathomimetic activity means that these drugs are, these beta blockers, they are not complete blocker. They have little sympathetic activity. Okay, so these beta blockers are not complete blocker, they have a little bit of sympathetic activity. Can we call these beta blocker as partial agonist? Can you call these beta blockers as partial agonist? Okay, so let's write the names of those beta blocker. You'll write B, okay, B COPA. Okay, first bopindolol, second you will write pindolol, A for acebutolol, celiprolol and oxprenolol. This question was asked previous year in PGI exam. Pindolol and bopindolol. Pindolol and bopindolol. Just try to remember these three drugs. Okay. Partial agonist means that they are not complete blocker, they have a little bit stimulant activity. Can you tell me one great advantage of these beta blocker? The great advantage of these beta blocker is they are not complete blocker. These beta blocker do not cause, they do not cause or produce bradycardia. Okay, because they have little bit of stimulant activities there, so these beta blocker do not produce bradycardia. Okay, I hope it's making sense to you. They do not cause bradycardia. Okay, they do not cause bradycardia. Next is MSA. MSA stands for membrane stabilizing action. Membrane stabilizing action. So this is the last part. Let's understand. You know that in any cell, inside the cell we have negative charge, outside the cell we have positive charge. Sir, what destabilizes a cell membrane? Entry of sodium destabilizes a cell membrane. Do you agree with this part? So membrane stabilizing action means that these beta blocker, they block sodium channels. These beta blockers, they block sodium channels. Hence the membrane will remain stabilized. Okay. Now these beta blocker you will write use. First you will write use. These beta blockers are used as an anti-arrhythmic drugs. They are given for the treatment of, you'll write, they are given for the treatment of flutter and fibrillation. Why they are given for the treatment of flutter and fibrillation? Because they stabilize myocardium. Because they stabilize myocardium. Okay. So you will write the drugs are PM, slap. Propranolol, metoprolol, sotalol, labetalol, acebutolol, and penbutolol. Okay. If somebody will ask you which drug has maximum membrane stabilizing action, labetalol. Maximum membrane stabilizing action is by labetalol. And last point of the day is that these beta blocker, they are absolutely contraindicated in glaucoma. These beta blocker are used in heart, but they are absolutely contraindicated in eyes. Why? Because if you will give topical eye drops of this beta blocker, they will have local anesthetic action. What are local anesthetic? Remember, local anesthetic also block sodium channel on nerves and on trigeminal nerves. And because of this reason, the person will have corneal anesthesia. The person will have corneal anesthesia. Now, what does it mean? Remember, in glaucoma, when the pressure in the eye increases, the patient will come to the doctor when the patient will feel pain. And there is only one pain structure, one pain carrying structure in eye, that is cornea. In cornea, trigeminal nerves are the only structure which can carry pain sensation. If you will give this beta blocker, they block sodium channel. Trigeminal nerves will not able to carry pain sensation. The person will not feel any pain. The person will not come to the doctor. If the person will not come to the doctor, how you will treat it? How you will treat it? So, my last question, would you like to give propranolol in glaucoma? Would you like to give propranolol in glaucoma? हो गया बेटा बस. Would you like to give propranolol in glaucoma? This question comes very commonly. The answer is no. We don't give propranolol in glaucoma. Okay. So this finishes our ANS. So tomorrow, we will start with glaucoma, and after that we will start with CNS. So tomorrow we will start with glaucoma, a small topic, and CNS. Okay? Yes. Tomorrow never dies. Okay? I know you are hypoglycemic unaware right now. That's okay. Yes, timolol is used in glaucoma. See, we are not written here timolol. Tomorrow we will discuss timolol, how aqueous humor is produced. Everything we will discuss tomorrow about glaucoma. Okay. Okay. I hope you liked. If you have any doubt, you liked any part, you can post on club. No problem with that. Okay. Yeah, you can ask me your doubts on club as well. I know you are hungry, you are hypoglycemic, you are having palpitations and tremors now, sweating also. How M1 block reduces ACH? One student have asked. M1 block reduces ACH by autoreceptor. Vagus nerve, remember, autoreceptor, and the function of autoreceptor is to apply brake, just like clonidine. Just see the word you have written in your notes, autoreceptor. Autoreceptors, they apply brake. Autoreceptor are inhibitory receptors. They inhibit the release of acetylcholine. Okay, you want to see the first slide, okay? Okay, I'm showing the first slide. Okay, so beta, this is the first slide. Okay, this is the first slide. Don't worry if something is missed, these lectures will be uploaded. And you can easily hear them again and again. Beta, in pheochromocytoma, if you will give first beta blocker, alpha receptor will be free. Epinephrine will act on alpha receptor and there is vasoconstriction. Vasoconstriction will shoot up the BP and the person may die. Because beta blocker, if you will first give in pheochromocytoma there is epinephrine, it will lead to vasomotor, re-reversal of Dale, vasoconstriction will occur, BP will further shoot up. Hypertension with CKD, we give ACE inhibitor or ARB, AT1 receptor blocker like telmisartan, etc. Okay, quick revision. Okay, let's do a quick revision. So we have started today with anti-adrenergic drug, alpha blocker, beta blocker. Alpha blockers are vasodilator. Why? You are blocking alpha receptor, but it will lead to reflex tachycardia. Beta blocker are vasoconstrictors because you are blocking beta 2 receptor, but direct action leads to bradycardia. As they are vasodilator, they will increase blood supply to penile area. Increase in blood supply to penile area causes penile erection, so they will produce priapism. Beta blocker reduce the blood supply to penile area, they will lead to impotence or erectile dysfunction. Alpha blocker are अच्छे for diabetes and dyslipidemia. Beta blocker are bad for diabetes and dyslipidemia. You don't have to go into the detail. Bucindolol is an exception. Now alpha blocker are of three types: non-selective, alpha 1 blocker, alpha 2 blocker. Non-selective, competitive and irreversible, phenoxybenzamine, drug of choice for controlling the symptoms of pheochromocytoma, and with phenoxybenzamine, after that you will add beta blocker. Okay, first you will add beta blocker, it will lead to unopposed action of epinephrine or alpha receptor, vasoconstriction, further shoot up of BP. So in pheochromocytoma, alpha and then beta. Competitive, phentolamine, cheese reaction, clonidine withdrawal, corpus cavernosal injection for impotence and pheochromocytoma during surgery, tolazoline for angiography procedure. Ergotamine is the only alpha blocker which is not a vasodilator, which is rather a vasoconstrictor because it stimulates some serotonin 5-HT2 receptors. Then selective alpha 1 blocker, we have discussed the mechanism. Selective alpha 1 blocker, they end with the word zosin. So prazosin, terazosin, alfuzosin and doxazosin, they are used for hypertension with BPH. Prazosin is also the drug of choice for scorpion sting because in scorpion sting there is hypertension and pulmonary edema. Okay. Then alpha 1A blocker, uroselective blocker, they are only given for BPH. Okay, they are only given for BPH. So we know drug of choice for BPH is tamsulosin. BPH with hypertension we give prazosin. Okay, side effect of prazosin, first dose effect or postural hypotension. Start with low dose, give at bedtime. Treatment is midodrine. Priapism and floppy iris syndrome because there will be no mydriasis. Now for the treatment of BPH, we give open the sphincter by tamsulosin and prazosin. If sphincter is open, the semen may go upward, which is known as retrograde ejaculation. To decrease the size of prostate, you give 5-alpha reductase inhibitor, which inhibit the conversion of testosterone into active form dihydrotestosterone. The drugs are finasteride, dutasteride, used in prostatic growth, BPH, prostate cancer, male alopecia, and hirsutism in females. Alpha 2 blocker, yohimbine, used as an aphrodisiac. Alpha 2 plus 5-HT2 blocker, not an approved drug. Other drugs are written, no need to remember them. Beta blockers, first generation, second generation and third generation. First generation non-selective, second generation cardio-selective, third generation vasodilatory, but they can be both cardio-selective or non-selective. The drugs are written in front of you: PPP, TNS, BEAM, and other drugs which we have shaded. What are the special vasodilatory action? Either they will increase nitric oxide, beta-2 agonist, nepranolol, nebivolol, and celiprolol. Calcium blocker is betaxolol. Very commonly asked question. You have to remember this betaxolol. Okay, tomorrow we will discuss about betaxolol. Alpha-1 blocker, labetalol, bucindolol, nepranolol, and carvedilol. Potassium channel opener, tilisolol. So which beta blockers are known as combined alpha plus beta blocker? We know this 5 beta blockers which are combined alpha and beta blocker, but you have to remember only and only 2. You have to remember only and only 2, although there are 5 I have told you. Carvedilol, other properties we have summarized. So which beta blocker has antioxidant action? That is carvedilol. Okay. Then you'll write essential tremors are beta tremors. Idiopathic, we don't know why it occurs. It occurs in old age, essential tremors. Also known as familial tremors and benign tremors. Now properties, you know, longest and shortest. All beta blockers are racemic mixture, except timolol. All beta blockers are metabolized by CYP2D6, 3A4. Open potassium channel, tilisolol, close, sotalol. Beta blockers are metabolized by CYP enzyme, except nadolol, atenolol, sotalol, and acebutolol, NASA. So these drugs are water soluble, not metabolized in liver, excreted unchanged in urine. So they are liver safe, but they are contraindicated in renal failure. They are contraindicated in renal failure. Uses of beta blocker. If you want to block beta 1 only, beta 1 is present on heart and kidney. In kidney, decreased renin release, treatment of hypertension. In heart, all heart condition where heart is beating more, like MI, angina, HOCM, aortic dissection, CHF, your mitral valve, your tetralogy of Fallot. But they are contraindicated in those conditions when the heart is beating less, like bradycardia, acute heart failure, and coronary vasospasm known as vasospastic angina. So uses of beta blocker depending upon when you want to block beta 2. 4P, heat G, pheochromocytoma, prophylaxis of migraine, performance anxiety, and portal hypertension. I will tell you what is portal hypertension later on. Okay, in endocrine chapter we will discuss. Every hemangioma, this question has been asked. Last year this question came. Drug of choice for hemangioma, propranolol. Last year's question. Essential tremor, akathisia, and thyroid storm. Glaucoma, we know glaucoma we use beta blocker, non-selective beta blocker, but we will not use which beta blocker? Propranolol. You know the whole list of those drugs. Then side effect of beta blocker, if you want, you are blocking beta 1 or beta 2. If you block beta 1, bradycardia, AV nodal block. Beta 2, it will precipitate asthma, COPD, Raynaud's impotence and vasospastic angina, bad for diabetes and dyslipidemia. So in all these conditions, non-selective beta blocker are never given, but cardio-selective beta blocker can be given in asthma, COPD, Raynaud's and diabetes, dyslipidemia. But they themselves are contraindicated in bradycardia and AV nodal block. So all beta blockers are contraindicated in heart condition when the heart is beating less. Okay. Now beta blocker in diabetes, I hope we have learned they produce hyperglycemia because they inhibit insulin release. They cause hypoglycemia, glycogenolysis. They mask the symptoms of hypoglycemia except sweating, which is known as hypoglycemic unawareness. Special properties, intrinsic sympathomimetic activity, that means they little bit stimulate sympathetic receptor. Advantage, they will not cause bradycardia. Remember these 3 beta blocker, bopindolol and pindolol, same name, and acebutolol. Lastly, membrane stabilizing action. They block sodium channel, membrane will not stabilize. On heart, they have antiarrhythmic action, but on nerves, on eyes, they will produce corneal anesthesia. Patient will not feel pain. Do not give this beta blocker in glaucoma. The examples are PM SLAP, and the maximum membrane stabilizing action is of labetalol. And I hope this completes our ANS. Okay. Okay. So this finishes. You have any doubt, you can ask me on the club. Because beta, these drug NASA, they are excreted in urine. If there is renal failure, they will accumulate in the body. They will accumulate in the body. If they will accumulate in the body, they will produce toxicity. They may produce toxicity. So NASA wale beta blockers should not be given in renal failure, because their only route to go out of the body is urine. In renal failure, they will accumulate in the body. That will lead to toxicity. Okay. Type slowly. I am unable. You can use terazosin also. You can use prazosin also. Prazosin is a cheaper drug and the oldest drug, so most commonly used drug is that one. Does finasteride act on DIAs? See, you know dihydroepiandrosterone, that is a different mechanism. DIAs also form first testosterone. Testosterone will form dihydrotestosterone. So it only inhibits conversion of testosterone into dihydrotestosterone. Hypoglycemic unawareness, beta, I have already explained you very slowly. Okay, you are asking me your doubts. I can't read your doubts also. So what is better, you can post your doubts on club. Okay, you can post your doubt. First read the notes and then post your doubts on club. Okay, first read the notes and then post your doubts on club. See, there are many beta blockers. You can't remember each one of them. So what I have told you is sufficient for you. Okay. Don't go beyond it. You can't remember beyond it. Okay. So you are just an undergraduate. You cannot remember more than this. If you'll remember this only, that will be more than enough. That will solve all your questions. So don't go beyond it. Okay. The books are very vast. You cannot remember it. Be selective in your studies. Okay, what is important, read that first, then make concepts. See, general pharma we will just finish after the lockdown. Right now, general pharma we are not planning. We are first planning ANS and CNS. After that, we will plan for all those general pharma and everything. Okay. Redhima, so general pharma we will discuss when the time will come. We will do that also. Floppy means the iris is not responding. Why? Because the iris mydriasis is not occurring. Iris is just paralyzed. Meiotic iris is paralyzed and it is just swimming in aqueous humor, floppy, like this. Both beta blocker and beta agonist can lead to hyperglycemia. I have told you. Beta agonist produce glycogenolysis. Beta blocker, they inhibit insulin release. So they both may cause hyperglycemia. Both beta 2 agonist and beta blocker causes hyperglycemia. Okay, how do we differentiate between cardiogenic shock and vasodilatory shock? See, this is a concept of medicine. There are 5 types of shock and there are methods by which you can check what type of shock it is. Okay, there are methods. You will learn in clinical subjects. You do JVP, you will check pulmonary capillary wedge pressure, you check urine output, you check heart rate. There are many things by which you can differentiate between various types of shock. Can beta 2 agonists prevent diarrhea? They are not used in prevention of diarrhea. Beta 2 agonist. They are not used in the prevention of diarrhea. The reason of using beta blocker in pheochromocytoma is to prevent tachycardia. In pheochromocytoma, beta blocker are given to prevent tachycardia. I have uploaded a video of pheochromocytoma on Club. You can read that video. On DAMS Club, I have posted a special video only about pheochromocytoma. Okay? We have to talk about general pharma. First, let's finish ANS and CNS, then we will come to other topics. How erectile dysfunction occurs as a side effect of clonidine. The reason is it reduces central sympathetic discharge, clonidine, and there is no drive, no impulse to do any activity. A person will be lethargic, sedated, and these are the symptoms. When sympathetic activity reduces, it will lead to impotence. Okay? Because it is reducing central sympathetic discharge. Reason, Raman Yadav, we use beta blocker in pheochromocytoma to prevent tachycardia. Okay? Beta blocker are given in MI. We will discuss in cardiovascular system because they reduce myocardial oxygen demand. Why? Because they reduce heart rate, the demand of the heart reduces, which is a good thing in cases of MI. Yes, they have additional action. Prazosin and terazosin, they have additional action on reducing the size of prostate. Yes, you are absolutely right. But better the drugs are finasteride and dutasteride. Even better than finasteride and dutasteride is do surgery and remove prostate. Okay? So this is a surgical procedure also known as TURP, transurethral resection of prostate, which we do in BPH. Yes, high level of beta receptor causes insulin release. Yes, we will discuss this thing in diabetes. Beta 2 receptor stimulation causes insulin release. Yes. Beta 2 receptor, beta 2 causes insulin release, beta. You're asking me again and again. Beta 2 increases insulin release. Okay. So the last slide you want to see. Beta, here we are not discussing about sympathetic discharge on erection and ejaculation. Here I have told you that blood supply to penile area. If the blood supply to penile area will increase or decrease, penile erection or impotence can happen. Okay. So blood supply. Beta blocker should not be given when the heart rate is below 50. But sometimes if the heart rate is 80 and blood pressure is low, you will not give beta blocker in that case also. But the answer is 50 for that. Same reason dyslipidemia. Okay, dyslipidemia beta, same concept. On liver there are receptors, alpha and beta. Just like pancreas, alpha and beta receptor are present. Similarly, liver also has alpha and beta receptors. If you will block alpha receptor, again, LDL secretion will reduce, triglyceride secretion will reduce, HDL secretion will increase. Okay? Beta blocker can be used in LDH. Beta, what is LDH? Monica, what is LDH? Devansh, for pheochromocytoma, just hear the lecture again. I have posted a video also on a group around for pheochromocytoma. You can hear that video. Yes, sudden withdrawal of metoprolol causes rebound hypertension. That concept we will discuss in general pharma. Super sensitivity of beta receptors. Dyslipidemia concept is same. Crenal dyslipidemia concept is same. Just like pancreas and alpha and beta receptor, liver also has alpha and beta receptors. Membrane, remember resting membrane is negative, normally negative inside the cell. Sodium is the ion which destabilizes a membrane. So these beta blocker, they inhibit entry of sodium and membrane will remain stabilized. So the heart will not beat more, the nerves will not carry pain sensation, the membrane, so everything will remain in a resting state, stabilized or a resting state. No, I have uploaded a specific video on pheochromocytoma. Jay Kumar Patel, and all phenoxybenzamine, phentolamine drugs I have already covered there. Tyrosine, hai na? If beta 2 increases insulin, why is beta agonist bad for diabetes? Even they increase insulin release, Srijita, they still produce hyperglycemia. Despite increasing insulin release, they still produce hyperglycemia. So this is a very important point which I will tell you in asthma chapter. Beta 2 agonists, despite increasing insulin release, they still produce hyperglycemia because they cause glycogenolysis, glycogen breakdown, which is a bad thing in diabetes. Shrejita, despite increasing insulin release, they still produce hyperglycemia. If you think logically, there should be hypoglycemia, but still beta 2 agonists produce hyperglycemia, despite that thing. Okay. Beta, because cardioselective beta blocker Mohammad Shahjab, because cardioselective beta blocker, they have a little bit of beta 2 blocking property. They have a little bit beta 2 blocking property. So this sometimes can precipitate asthma. Sometimes they can precipitate asthma. Sometimes they can precipitate hypoglycemic unawareness also. Not very routinely. So they are not completely safe. They are relatively safe. Cardioselective beta blocker. They are not completely safe. Okay. They are not completely safe. Okay. So I think we can end our lecture out here. Eat food. Have a good meal. So till then, goodbye. See you tomorrow. You can post all your doubts there.